Good morning, and good morning. Welcome to Sports Docs program or track today. This morning we have Dr. Baumgartner, who's somewhere in the back, and myself. She'll be doing running biomechanics for the female athlete, and I'll be doing something called pink concussion presentation. And well, it is actually good that this is a nice tight room. We have like a full house, so I really do like this. So we're going to get rolling here. I practice in South Florida. That's not me. I practice in South Florida. I've been in practice 30 years. I'm not going to give you too much more than that. I've been able to accumulate some letters after the name that are really involved with neurology and chiropractic. But we're excited to be here. This is Catherine Seneker. She is actually a licensed clinical social worker. She's the executive director of Pink Concussions. That's their website. And she's an amazing gal that has really pushed forth this understanding and desire for understanding among concussions with ladies and their recovery. So this is Doc Sports, a little bit here. We want to encourage you to join. They got the booth out here. Marchette is here. We have the trip later. If you're going to go to the stadium, you want to make sure you see her in between if you haven't signed up. But it is really a wonderful organization. Now, Dr. Barron is not here, but I'm going to tell you a little bit about this guy. He's been in practice a little over 30 years. And for most, I would say, for most of the sports that our profession is involved in on the legitimate level, meaning like, oh, you're the official chiropractor for, he has been really the impetus for a lot of that. With football, with hockey, with baseball. I mean, the guy's really worked tirelessly, and so I'm glad he's not in here because I don't want him to, he'd say, no. But he really has put in hours and hours and just thousands of hours working for the benefit of the profession. He always told me, I want to leave the legacy that our profession is better from the things that I did, not just in my practice, but on a larger level than just working, in my own office. So really just meet him today if you haven't, and I think you'll really like him. He's such a personable guy. So you can connect if you're into social media things. They really like you to connect. They do a lot of giveaways, and it's going to become a very excellent organization for the docs to stay connected and to develop a network that we can work amongst each other. These are the different sponsors. Performance Health. I told you if you didn't get one of the little cards, you want to get one of those before you leave. And on there are different times for Performance Health. We're doing little teachings at the booth, but the ones in kind of the aqua, they're going to do giveaways of these beautiful CLX stations, and they don't have a lot of people, so you go by and drop your name in and hang out for that little session. You may win a really expensive CLX station for your home or office. But we're happy to have you here. All right. So Pink Concussions, what is this all about? They had a big summit this year, and I was in the plane, on the tarmac in Miami, and we didn't go. I had the hotel, I had restaurants reserved in Toronto, I had meetings up there with people, presentations, and they grounded all those 737 Maxes. Remember that? I was like, you gotta be kidding me. And then the next day the flights were a disaster, so I didn't go. But I had friends that were sending me pictures and images, and so I have some of that information for you. And I mentioned this yesterday, that if concussion is the invisible injury, because a lot of people say, you look fine. I mean, what are you talking about? You're fine. Coaches, clinicians, spouses. It's difficult because you don't see something on the outside. Then the females are the invisible population. I think I said that a little funny yesterday, but that's really the statement. And it's just getting more and more attention, so maybe they're becoming more visible at this point. So how do the women get concussions? Car accidents are a very common way of getting concussion. And I'm sure you know, you do not have to hit your head to have a concussion. You do not have to be knocked unconscious to have a concussion. So all that stuff is gone. You don't have to vomit and all those things. Those are not really pathognomonic of having a concussion. You can just have a whiplash and end up with a concussion without actually hitting your head on anything. And so, of course, sports, that's a very obvious one. Military is becoming more understood, of course, with the different blast issues. And then domestic violence, which is actually a very big one. So it's a really important topic. One of our colleagues just got appointed to a national, I believe, domestic violence task force. One of our chiropractic colleagues that works in chiropractic neurology for us, she just got appointed to that, so she's helping to understand the outcomes and what we can provide in terms of care for people. All right, so a couple different things here. These are all slides that are available from the Pink Concussion website, so you can go there and download the whole presentation, but you also can get them here on mine if you get them through the FCA. Risk of depression is twice as high in females that have concussion. Females have differences in neck structure and movement. We know that. Hormonal differences affect recovery. If they're in a reproductive cycle, earlier onset of anxiety, more headaches are suffered by women. They tend to ruminate on the symptoms more. I mentioned that yesterday. It may be due to a blood flow type of issue in the white matter tracts. Adolescents and young women experience abnormal menstrual cycles post-concussion. So there's a lot of other pieces to the puzzle dealing with a female athlete that gets concussed than a male athlete. So these are brand new slides I dropped in for you from some of my colleagues. Adolescents and young adults, they have 4 domains. So these are the 4 domains that most people in any type of concussion assistance will look at: physical, cognitive, social, and emotional. So what I want to posit to you is that you want to be able to measure these a little bit. If you want to work with, there's a lot of your patients that have concussions, and they won't say they've had a concussion because they don't think they had a concussion because they didn't get diagnosed with a concussion. They fell in the house, right? An older person or a younger person fell, or in the yard, or playing a sport, or they just banged their head really hard, or a child at the playground, or youth soccer, and no one diagnosed them because they seem fine. So there's a lot of people that have concussions or what's the word? Not post-concussion syndrome, but less than a concussive force. I can't remember my phrase right now. But they have a low concussive force, but they have some repetition of those things. So there's a lot of things that, in my estimation, create changes in the brain, adaptation, that don't look really like a concussion, but a person starts to go through alterations. And I'll touch on some of those. So physical, cognitive, there's ways to measure those. Social, that's not so easy to measure. Emotional, there are ways to measure that. And then we have girls' infancy through school age, and this affects their academic and school performance. 11 to 12-year-old girls. So we get a lot of young people that play on teams, and there's no baseline for them. In fact, a really interesting story is that we have some of these kids, and the mom says to me that plays soccer, this happens to be young boys, could you do some of that testing for the team, like baseline testing? I said, sure, we could do that, because she brought her kids in, and as a patient, we did that for them. Balance testing, and sure, we could do that, so let's just get the coach's name. So the coach, so this is going back and forth for about a month. The coach gets us the name of the sponsor for the team, a hospital. Okay, so they're the sponsor not only for the team, but for like the league. You know, they're not the only sponsor, but they're the big sponsor. Uniforms. They don't put trainers at these events. There's too many games. They don't put anyone there, but they give some money. So we get in touch with the administrative person, not a medical person. They say, no, we don't want any gratis or complimentary baseline for the kids. It's a conflict of interest. Okay, so all these kids, like hundreds and hundreds, actually in the state of Florida, thousands, playing youth soccer, no baseline. That's not so smart. And what is it? It's just because of this attitude or whatever's going on there with that. And I was like, see, this is the problem. Because you think, oh, I'm going to learn this and everyone's going to be open to it. Absolutely not. They're not open to it. The biggest challenge, one of the trainers that I work with at a local high school, she says, you know who my biggest problem is? The coach on the football team. Now, they're not all that way, but she says, I mean, he's a great guy, but we have helmets with telemetry, and he'll make the speed players switch with players that don't play that much because, imagine, right? So he's got a job. He's a high school coach. He's got a family. They got to win. Even at that level, they have to win. And so if the best players are getting high impact ratings and they're being pulled out of games because of data, then they don't win, his job's on the line. So they didn't embrace me when I came back. Oh, I'm ready to go. They're like, yeah, I've met with the people at the hospital in their concussion rehab department. Yeah, we do that. Yeah, we do that. Very nice, very pleasant, show me around. But they don't have the specificity because they have too much volume. That was the thing. It's just too many people, so everyone's getting basically the same thing. Most people do get better when they have concussions, the majority of them, without doing much. But I would also say, as the research is coming in, if you don't measure a lot, then they may look like they're better. But we measure things on such a discrete level, on so many little factors, we really can see that, yeah, you've improved in 7 out of 10 measures, but these 3 are important and we can improve them and it's not that big of a deal. So measurements are very important. Can you hold it? I got a lot of things to get through in a short time. Women of childbearing age, also very important, impact on their libido, their mood, their hormonal changes, motherhood, very important. I'm connected to quite a few ladies on social media through our office that have had TBI, and it's really affected their ability to be the mother they would like to be. So these are the 2 ladies, Eden Dales, Lauren O'Kell, that I put together this presentation, these slides. If you want to just take a screenshot of that, or if you just want to get it later, you can, and then you can get more information from them. You can get this entire presentation. Ready? 5, 4, 3, 2, 1. Good. Okay. All right, so what are the critical areas of the brain? This is really important for us. For sport-related concussion, that SRC. So now they're breaking down concussions into particular types of concussions, where they happen, what are the population that's involved with that. So the important areas here are the frontal lobe, we'll call it that, or that's pointing more towards the cingulate, but let's say the frontal lobe up in here, right? You're all familiar with this frontal lobe area, very important. Brainstem down here, and cerebellum. So these are the 3 areas of our focus that are injured commonly and are needed to be rehabilitated. So how would you measure those things? So how would you measure something in the frontal lobe? Well, you might need to measure something like balance or memory, a working memory task, an episodic memory task. And there's ways to measure those pretty easily. Mood, how would you measure someone's mood? Yeah, you're not a social worker or psychologist. Paper inventories. There's paper inventories that you can get PDF, a Beck or a Hamilton depression or anxiety index. Someone's saying, yeah, I have, even if they just have pain, so some of this should cross over. Yeah, I have pain, but man, I've been dealing so much with anxiety and I'm on medication. It's not a bad idea for you to get an index. Oh, let me have you just fill this out as part of your paperwork and put it in your file. And you look at that and you have that scoring, or the depression one. Someone says, yeah, I'm really down. You have them fill that out and then you put it in there. And actually, you start treating them, and at the end of their care cycle, whatever that might be, or 4 weeks, you say, okay, I'm going to give you that. I want to have you do that again. You're noticing maybe they're improving. They do it again. Actually, you have a really interesting quantified measurement that is validated in psychological standards of how their mood shifted and changed based on a self-graded assessment. It's kind of cool. So I can tell you more about getting those. They're all free. They're online. How about brainstem? How would you measure that? Autonomics. What would that be? What would you measure for autonomics? Put a pulse ox on them. Check their blood pressure, but a pulse ox is faster. You can just have that. You can get them off Amazon very cheap. You can get them at the CVS, wherever, Walgreens. And then you can just put that on people. It's actually a good idea. It's a good practice. You know what? Whenever I take that out, here's what people do. They just, why do they do that? Because they're used to it. So it's not a bad thing, and it helps you with your risk management, because just put a note in there. Even your staff can do that before you get over, especially if you have older people that are fragile. But what about younger people? So we had this young soccer athlete. She came in because of an Achilles issue that was chronic, like over a year. And she was maybe, I think she was about 13, 14, young teen. So non-competitive concussion, chronic Achilles injury. Dad brings her in, and she sits down on the table, and I put the pulse ox on her, and it's like 125. I'm like, 125? That's kind of high. I'm looking at her. She's not like, sweating, not diaphoretic, anything. She's okay. She's just sitting there. I'm like, lay down here for me. She lays down, goes down to like 100, sits back up 130. I'm like, oh, this is not right. This is not what it's supposed to be. So she was presenting with a dysautonomia. So the back story of that is that this Achilles injury, she injured her Achilles. She went, they did an MRI, she had a small tear, they did rehab, they did the whole process, orthopedists and PTs. They went back, she was still complaining. Oh, she's very emotional, still complaining, did another MRI, perfectly healed. We don't know why you still have pain. But if you're dysautonomic, maybe you're not shunting blood down to the extremities properly, and so it may have limited healing. I can tell you that's what we believe happened, because as we started to treat her, she stopped complaining of the pain in the ankle. And I really didn't do anything for the ankle. I couldn't do anything better than they did. They fixed it. Or the Achilles. So that's interesting, right? Eye movements, which I'll talk to you a little bit about. You'll do some of those. Well, it's so tight. We'll do it maybe one or two people. Heart rate, pupil size, look at their pupils. All these things are pretty quick. You can do it when you're looking at them and doing your exam, as long as they don't have really dark eyes. You might be able to see that, or look at them with a pen light. This is pretty much now, so many people have these pen giveaways, so I pretty much have this in my pocket all the time. I feel like Marcus Welby, so I can kind of look at, some people don't know that, but only older ones. Marcus, who the heck is Marcus Welby, famous chiropractor? Actually, I was at dinner last night, and I'm talking to a guy wonderful young guy, about to graduate chiropractic school. You know who Jim Parker was? Who? Sid Williams? Clay Thompson? Oh, yeah. These are, if you don't know these guys, you should have some great stories. I have some great stories about a couple of these. Cerebellum tone, the tone, the movements. I was with one of our docs yesterday, and we were just looking at her daughter playing games, and we were having her do some things for alternating movements, just to kind of get an observation there, and just quick things. So a lot of my exam happens just by observation. In fact, Dr. Goodhart would say all the time, measure, 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 measure. If you know Dr. Schmidt, he repeats that adage. And then also, it's very important, some of the best things that I've learned from people in practice longer than myself is your observation during the meeting with the patient. Observation. You can learn so much about what's going on with a person just by observing them walk into your office, come into that room, and sit down, and how they're presenting themselves, their handwriting on the page. So I'm already getting an assessment. So I've learned from some of the best, I believe, clinicians in our field, that observation is very important. Okay, so here is the aspects of what we'd like to share with you this morning, a little after 8:15. We want you to be competent and comprehensive. Competent and comprehensive. And so what that will entail is that you're going to have to do a good history. I think I have some arrows here. A good history, an exam, and these things stand for, so I'll mention in a moment. This is a platform I'm going to share with you very briefly called Cambridge Brain Science. I have no disclosures with them. Or EQ Highmark. These are two programs or platforms electronically, and this is where a lot of the records are going, and this is the assessments are going, that you can actually get this into your own system and work with it, and then you can do other evaluations as part of your overall montage of care. So a VOM or VOMS is the vestibular ocular motor screening. This is the standard. So if you talk to somebody that was a physical therapist or works in vestibular therapy with concussion rehab, or anyone that works in concussion outside of our profession, you say, well, I did a VOM on them. Oh, you did? Then you would be talking the same language. But if you didn't look at the eyes and you said, well, I believe they had a concussion, and I looked at their posture, and they had a high shoulder and a rotated hip, you're not talking the same language. That's like, I'm not going to say Chinese because it's just different. It's not in the same realm as concussion assessment. But if you said, even if you said, you didn't say VOMS, I just looked at their eyes and I noticed they couldn't converge very well, that they complained that it bothered them, it gave them a dizziness feeling when they pursued after my thumb. Now you're speaking the same language. So here's something, I don't want to say I have a pet peeve, but I'm concerned that we say, yes, we treat concussions when we have zero training. It's not an adjustment fix all the time, although adjustments are very crucial to repairing some of these people. But it's not just a simple thing like, oh, you had a concussion, lay down, an atlas adjustment. Although it's going to be part of that, it may not be the only thing. So I just don't want you to leave that thing on its own. And I will give you, I think it's in here, a way to get a training through the CDC that you do online on your own computer, and it's complimentary. And you get good background and understanding of some of these things. So that way, if someone says, what's your training? Not that they will, but what's your training? Oh, well, I completed this CDC Heads Up course. Oh, okay, good. So you have some background. And that's I'll show you. I think it comes up here. So I'll show you how to do that. The neuropsychological testing is Cambridge Brain Science. It's gamified testing that has a massive normative database that you could have the person do on the computer at home or in your office. And it takes, each test is like 3 minutes. And they have them packaged. If the person's had a concussion, if the person's had a stroke. So they're measuring these domains in the brain that are accepted in literature. Like someone would go for neuropsychological testing and they'd pay thousands of dollars and they'd have these extensive tests for hours and it just totally wears them out. Well, this is a way to get a level of that is standardized that you can use as well. And it's really great because even if you say, I'm not really into that, I'm just really staying with the chiropractic, this is not a bad thing to have in your arsenal for measuring things. Because I'm about measuring things that are going to give me value, right? If you measure range of motion on me, and I'm a patient of yours, but I'm complaining of headaches, and you say, wow, look at the range of motion has changed in your hip, I don't really care that much. I mean, it's important, but, right, so we have to measure things that are relevant, and sometimes you got to think, how am I going to measure that with people? So there are tools out there. And then the symptom assessment. Getting a good symptom assessment is a very big part of that. So make sure that you're getting some kind of good history and talking with them about that history. This is something I've been retraining myself because I kind of got into a little bit of a pigeonhole with that. So here's your VOMS, your vestibular ocular motor. And you can see University of Pittsburgh, Department of Orthopedic Surgery. So this is the accepted evaluation. So it looks, yeah, it's in there. So it looks like this. Okay, Doc, let's just do it real quick here. Well, let me have someone, you want to come on up? You see it there, but we'll just do it here. So you can see, what I want you to see is, yeah, you're good there. I want you to see the distance that I am away from him and get an idea of that, right? So I don't do it with the pen with the light because the light's bright and it bothers people. But I'm going to say, just watch now I don't do this because I don't know where he's looking. Is he looking at the top of my thumb, the middle of my thumb, the bottom of my thumb? So I like to refine it, and I say, you see just the end of my thumb here? Just watch this with your eyes and follow it. And I go back and forth with him, and I'm looking at his eyes to see if they're just tracking smoothly or if they're jumping at all. And then I say, okay, now I'm going to go up and down. And I'm not going here and here because it's way outside of the oculomotor range. This is pretty normal stuff in here. And I'm not up too close to him, and I'm not back too far across the room. And I don't particularly like to stand with myself behind it because I'm wearing a checkered shirt. And if you have anything that could be visually disturbing to somebody, so I pull my thumb out here, I have a white door, and I just have them do that with no background. So pursuits, up and down. Okay, what's next? Saccades, or saccades, depending on the way you like to say it. It is a word derived from French for the way a horse flips its mane. It's a fast motion, and so these are fast eye movements, saccades or saccades. So we'll have my thumbs here, and I'll say, look at my nose. When I move a thumb, look to one of them that moves and stay there. Okay, there, there. Stay on the one that moves. Here, here. Stay on the one that moves. Here, here, here. And I'm looking to see, do they move fast and look like the same speed? It's just observation, so you'll have to do a lot of that. But you can do that quick, and I'm looking to see if they kind of double jump, or if they go really slow to one side, or they can't move them to one side. I've had people say, I'm trying to look there. And then I do it vertically, so I put my thumbs like this, look at my nose, I start here, look at the thumb that moves, and stay on it. Here, 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 here. Again, look at me here, 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 here. Good. So you feel how you have to kind of move your head a little bit. Then we also have the horizontal vestibular ocular reflex. A couple different ways to do this. And near point convergence, let me do that one first. Near point convergence, so this is the measurement that all optometrists use. I'm going to have you hold that, Doc, for a minute. So I'm going to be here, and I'm going to have him converge as I come in. And I'm looking at his eyes to see if his eyes just come in. People who've had concussion, you'll come in and, oh, I don't like that. That's a very common response. But you're also looking, and have them hold it. So I'll do it maybe 2 times. I'll come out. I won't do it really fast. I'll come in. I'll look, I'll watch the eyes. I'm not looking at my thumb. I'm looking for one of those eyes to do this. Just drift out. That's really important. So an optometrist may say, hey, doc, they had a CI on the left of such and such range. CI is convergence insufficiency. It's very common. It's actually common in a lot of people. ADHD kids, look at it with kids. So you say, oh, they're not concussed. No, just look at it. Children with autism, if they will make facial contact, get a puppet. Put a puppet, little finger puppet. Watch the puppet, and then you see one of those eyes drift out. Very common ADHD and children on the spectrum. And then you know, oh, I got to work on that region of that brain that controls that perhaps. Okay, so convergence, near point convergence. They measure them very specifically in optometry. You just have to say convergence caused a withdrawal response. Patient didn't like that. They had a weakness in one eye. It didn't converge. It went back out, drifted out. Visual motion sensitivity. So let's have you put your thumb up here and just stand. So what you're going to do is you're going to look right at your thumb, and what I want you to do is, and I don't think I can do it too much. You're going to go like, yeah, I can do it. You're going to go like that, back and forth. So he's suppressing the eye motions by keeping them fixed on that. So you do that with somebody with concussion that's having some residual symptoms, and they say, oh man, that makes me feel not good. Okay? So that is your visual motion sensitivity, and then the vestibular ocular reflex is one where we can just do it like this. So just follow me with your head. Your head and eyes. Okay? So I'm watching to see, so I want your eyes and your head, so like your nose has got a string to my finger, right? Move your head with me. Okay, now keep your head still, and now just watch again, so the smooth pursuit. So you have these different versions of looking at this vestibular ocular reflex, okay? Thank you. So these are the important tests, and what are you looking for? You say, I don't do these things. You're just looking to see if it looks abnormal, one direction to the other. And just make a note, because that's a good thing to have in your note. So an elderly gal falls, she comes in, and you just look at her eye movements, and just look at her convergence, and see how she does, and make some notes on that. Because a fall and a head impact, they happen all the time. They happen all the time. So there's a little chart that you can get, and you can just check it off if you wanted to go that far. It was developed in conjunction with multidisciplinary experts. It assesses 5 areas: pursuits, saccades, horizontal vestibulo-ocular reflex, visual motion sensitivity, and near-point convergence. And it's 90% accurate identifying concussion patients after a acute concussion, a recent one. So people may have had concussions years ago, or they've had subconcussive blows. That's what I was trying to think of 15 minutes ago. See, that's that older memory already. It takes me 15 minutes to remember. Again, identifying vestibular and ocular problems. So we got to really understand this vestibular system a bit more. So we have 3 major inputs to the brain. I kind of diverged from this slide to me for a moment. 3 major inputs: visual. How many people had a little insufficiency with that? Look around. Keep your hand up for a minute. Okay, a few. How many people in this room, okay, good. How many people in this room think that they've had a concussion in their lifetime? Look at that. I'm going to tell you, I rarely have patients that come in that say, yeah, I've had a concussion. And I treat concussions. Isn't that odd? People don't, no, I didn't have a concussion. If you ask me, I think I've had around 10. I know, not good. But I've never been diagnosed with a concussion because I grew up in that era when, how many fingers? Good? Walk it off. Here's some ammonia. You're okay. I've had car accidents, rollovers, not my fault. You know, I banged my head quite hard. I felt a little starry-eyed. So I'm estimating I had at least between 5 and 10. So look at everyone in here. So you have patients come in, the next 20 patients that you have come in, you ever had a concussion? No, no. And I'm not saying they have. I'm saying they've had subconcussive blows that may have changed their neuraxis and now are causing contributions to their motor output that are not so good. Wow, that's pretty amazing because we're treating them for those things. All right. Cambridge Brain Science, we're going to hit the ground running. These are just pictures of the tests. They test memory, attention, verbal ability, and reasoning, 4 domains. So we don't test for IQ anymore. We know that. We test in these domains for people with cognitive function. So I had a patient came in just recently with a stroke. He's a former firefighter. We test him. It's one of my baseline tests for everyone. We have ADHD kids and young people. We test them with the attention package. So when I have my results and they're doing a bit better or maybe not so much better, and the parents say, I'm not really sure, let me show you the results. They went from a 27 percentile to an 87 percentile. They are improved on their task performance and attention. Maybe it's behavior. Really? Yes. See how those things work? Maybe. I'm not sure. But kids learn how to do things. They know what they do and don't want to do. So I'm like, listen. Or impulse control with some of our concussed people. Impulse control testing, score very low percentile, much higher later, and then the parents again say, you know, they're still on the social media all the time, I can't get them to turn their thing off at night, and so it may be more behavioral and a learned behavior, because they can control their impulses, or eating chocolate, or whatever. Because we're all like that. You have your behaviors, but your brain drives your behavior like mine. So these are the different tests that are in there. I recommend looking into it. I can get you connected with them, or you can get connected to Cambridge Brain Science, and I think that you might like their activities. So you have it on your computer, not just intelligence testing, very good, published in the Journal of Neuron. There are well over 250,000 people in the database. So when I measure people against their own age group, I know that this is a pretty darn good standardized reading. EQ brain tracking, this is Dr. Baumgartner is interested in this. You can get this also. A patient would get it on their phone as an app. You pay for it, and then you would pass on the charge to them. They have it for 1 year at a time. And they can do the online tests for concussion on their phone in a gamified fashion. You know how good this is for kids, who their coaches and all those people are? This is a great thing. And you get the whole back-end data that you can look at and see how they're doing, how they're performing. Watch the video.
The brain is a complex place. Each one is like a snowflake. Every day it changes. Some days all the pistons are firing. Others can feel a bit slower. It's time for testing that addresses these differences. Introducing EQ, concussion management and neurological testing that is built for the modern brain. Based on the latest research, it contains tests to measure issues such as concussion, anxiety, lack of sleep, and more. By allowing repeated testing and tracking progress over time, EQ establishes a healthy range of results, making it easier to identify outliers and potential issues. Then, after a worrisome collision, you can run a test to detect any significant difference from your normal, healthy range. Immediate analytics allow you to share results and alert others. Better yet, our tests are designed as fun games that are quick, easy to play, clinically proven, FDA listed, and, did we mention, fun. EQ is a vital tool for anyone involved in sports. Visit highmark.tech or download EQ Active Brain Tracking on the iOS App Store or Google Play Store today for your 7-day free trial.
There you go. No disclosures. I don't get anything from them. I love this technology. Yes, sir.
What does the E stand for?
Good question. You'll have to call them to get that answer.
What?
You'll have to call them to get that answer. Very good program. I love this platform. So if you can't get, I'm sorry?
You know what E stands for?
You know what? I don't.
Oh, okay. I just thought it was.
I don't know.
Okay.
It stands for,
Equilibrium?
I don't know.
Easy, quick.
I will look into it. No one asked me that. I never even thought to ask. Anyway,
Nobody asked you.
Doc, you threw me under the bus with that question. I should have just made something up, but then you'll check in. I'll be wrong. Yes, last question. I got to keep moving.
How does that compare with right eye for concussion tracking? And
Totally different.
Totally
Balance testing, other domains.
Okay.
So the reason I like this so much is because, like I said, if you can't get into the venue or because they're saying, no, we don't need you because we are doing all this, you can put it into the hands of the people who can do it on themselves, the kids, right? You can put it into their hands and you have access to, and you can share the data. You can now develop a relationship with the trainer and say, listen, so if you have a relationship, it's a great thing because having the kids, especially the females, evaluate themselves privately is probably better a lot of times because they may not want to talk about that. They may not want to share about that. And it's gamified, and you'll be able to see these results. So I think that it has tremendous potential to get the operation in the hands of the most needed person so they can assess themselves in a way that's fun. And you can do it weekly. You can do it weekly. You can do it, and they can do one-off tests on it. So it's really a marvelous device. So you'd get your own account, and that's how you would do that. And I'll find out what the EQ stands for. All right, balance error scoring system. This is what all the different colleges use primarily. Now they're starting to purchase platforms for measuring balance and dynamic balance and posture. But this is what they use before that, which is the balance error scoring system. So it is just having people stand with firm stance or on a firm surface and a foam surface. So you have two different surfaces. I don't think we're going to have time to demo it, but we will do it later today. And then they're standing in a tandem stance and a single leg stance, and you're measuring how many errors. So errors for a person are motion. So they're standing here on a firm surface. So the majority of the input is somatosensory. And then a small percentage vestibular and a small percentage visual. And then when you stand on a foam surface, the majority of the input is vestibular. So you can kind of get an idea of which of these systems is weighted or where the weighting is coming from. The input is more vestibular or more somatosensory. And then if they have more problems in one of those, then you say, maybe there's more of a problem in that vestibular system. But when they're standing like this. They're standing on their non-dominant leg. And this is all in the document here. And they're standing in a tandem stance with their dominant leg in the front. Oops, this way. And you're measuring errors. And errors look like this. 1, 2, 3, 4. So you just count the errors. So there's some subjectivity to that, right? But as you practice it more, and it's very simple. You could even teach a staff member to do that. And then you would say to a trainer, we use the EQ system. They won't know what you're talking about because that's very advanced stuff. They just don't have access to that all the time. We did a best test and I scored a 22. Wow, really? And then we looked at near point convergence was actually caused them a withdrawal response and they didn't feel well. And their pursuits really caused them an issue with feeling nauseous. You did all that? Then you're in the right field. You know what you're talking about. So that's what I'm saying. I'm giving you the right language and the right tests so that you can be on par with people evaluating concussions. And, side note, a lot of your patients have had head impacts and have problems in these areas. And now you're able to kind of look at them. So you can get a little card like this, all on the internet, free stuff. And then you can get that sheet. You can print that out, put it as part of your file. You can just do the check off and fill it in, put it in there. Now you have a score. Do your regular types of therapies, even in the absence of a concussion. If you're not measuring balance, you're really not on the standard of people that are measuring things when it's regard to the brain or athletics. You should be measuring balance in your athletes periodically. And do your adjustment and remeasure. That's kind of a neat teaching tool. I always found that better than pointing to a chart to educate them is here's your balance, here's your adjustment, how's your balance? Wow. That's a wow. Or a muscle weakness or a range of motion if they're complaining. So the demonstration of the improvement, if you can do that, is really powerful. Okay, I'm going to be at their booth today also. You want to stop by there and check that out. Because there's different brain waves, and the brain waves are affected in concussion. We do a lot of measurements on this. Brain tap is a therapy. I'm not going to say too much more about that, except that stop by, visit the booth, try the therapy, and then find me and talk to me, or you'll get my email. You can get more information. I think it's something that many of us should look at because it's a high-tech item at a low price point that improves brain activity through electrical function, which can enhance your outcomes with pain, but especially people with concussion. But there's a way to use it. There's a way to use all the tools, right? You don't just buy this and then slap it on people with concussion because you can blow them up too. But it's not as dangerous as some of the other things. It's not a dangerous thing. It just may not, you have to know how to utilize it. It's not that complicated. You're doctors, you can learn. And it's very effective. I've seen some really great changes. That's what it looks like. You might want to check them out. They are one of my sponsors as well. Okay, we talked about those as a recap, those couple of tests. Practice those. Get them off the internet. You can see them right there. You can look at the PDF. Brain Tap, stop by their booth. Cambridge Brain Science, you can find that online. Check that out for yourself. Do a little tour. EQ, I'll find out what the E stands for. Someone asked me about doctors training. We do bring in doctors to our center for a fast approach to understanding technology and integration of concussion and other types of conditions. We're not the Carrick Institute, so I don't give you any type of certificate of training or anything of this nature or CE hours, but I can get you up to speed on how to implement things, and we do that with physicians. Office number, mobile number, all the social media stuff you can find us. Questions? Yes, sir.
Do you find any correlation between this work, iridology, and sclerology?
I'm not familiar with it other than knowing about it, but I would love to see the crossover and what does this mean. Sometimes we have an explanation for how something works because we don't have all the data yet. We don't have the science yet, right? Just like they're explaining in the early 1900s how chiropractic worked. And now we have data with Dr. Heidi Habeck and others et al. That is showing us how it's abnormal afferentation, processing, and efferent function. And so I would really like to understand how some of these other types of healthcare processes integrate with brain and neuroscience. It would be brilliant to know. You should write a book on that. Yes, sir?
Hi, Mike. Just from before, when you were talking about coaches being resistant to you doing baseline testing because they're worried you're going to use it as a way to take players out of play, are they resistant to something as really simple in middle school and high school of just completing a simple questionnaire, a self-evaluation about their balance and memory and things like that, just so you have something, or are they even resistant to that?
Well, they use impact testing at all the schools. They pay for that program, so they have an online computer-based program for their athletes, probably in the middle schools or what we used to call junior high. And so they do that, and they say, no, we're covered in that area. Unless you have a relationship and they're open, and then they understand, well, it's more than computer, that we know now you have to have the 3 levels. You have to have the cognitive, you have to have the balance, you need to have the visual aspect to have a proper evaluation of concussion, especially in our girls and our boys. I mean, the ladies suffer more, but a lot of people are dealing with these. So I think it comes down to relationship as a possibility, but know that going in, know where they are. We already got that covered with impact. Why would it be different? Well, we do balance testing, and we do a visual evaluation. We'd be happy to do that.
And you didn't mention SCAT.
I didn't mention SCAT. Later I will. Very important. SCAT, S-C-A-T, it's an updated testing, but it's for the immediate post-concussion, not for a longer term. You're probably not going to see, I'll give 1 second, you're probably not going to see the immediate because they're being handled, the ones that are obvious, bam, they're on the field, unless you're on the field. You're going to see them later, and they're maybe not complaining, and then you may be doing these evaluations and finding things. Yes, ma'am?
Just a quick question about the EQ app. Is this strictly pediatric or appropriate?
No,
for
I use it with adults too.
Okay.
Yeah, I use it with people who don't have concussion, people with anxiety, sleep, because it's giving me data on memory and so forth. You'll see that again. That's gamified. The Cambridge I send out, I control that. That one I let them control when they want to take it. I'll make recommendations, but I'll get data in. Yes, sir?
When you do the VOMS test, is there a minimum threshold, or is it just a relative scale of they start and then you see how they change?
Yes. Your second, you're observing for how they respond to it, subjectively, and then how they are feeling. Subjectively, and then how their eyes are moving is what I do. So I make notes on eye movements, and then how are you feeling? How they make you feel off? Yeah, turning my head this way really doesn't feel right. So those things. Yes, sir?
I just suggest running for school board. Open up a lot of opportunities.
Me?
No, not anybody in here.
Oh, us run for school board? Yeah, I guess if you don't have enough on your plate already, right?
For the EQ, how is it easy? When I was a player, I had a bunch of my teammates that faked the impact testing. They took longer because they knew they were going to have 2 or 3 concussions.
Wait, say that louder. So a lot of student athletes will...
They will take their time. They'll get questions wrong or things like that. So during the season, and as they're on their 3rd concussion, they will be substantially less, but within the same time as when they started. So is the EQ able to differentiate between maybe someone who's trying to fake it, or that data's not quite there yet?
There are some aspects of it that you can't fake. There are some that you can fake. Right? So there's a symptom survey there. You can put nothing. You're faking that. I mean, you could fake that, right? But there's another one that you can't fake in there. So they try to build in something to kind of have a backup on that system. Well, I hope that you enjoy the sports track today.